So we have to first get you into a space where you can think clearly, and then you can see if there's a problem worth solving. But the emotional pain can be so extreme. A person might be really kind of immersed in this idea that they want to die. And people aren't choosing to dysregulate. It's something that's happening at the physiological level, right? A series of circumstances, their whole life story, whether they were born emotionally sensitive or they developed it out of their traumatic experiences. Sometimes these conditions are so strong that when we try to take traditional approaches, it just makes them feel even more invalidated. So core concept here in DBT, which again is just another kind of CBT that's just focusing on a specific angle. One is that all things are interconnected. Change is constant and inevitable. All causes have causes, right? Before I was talking about self-compassion and understanding that this idea that I should have known better is missing, that before you were supposed to have known better, you also didn't know better. And before that, there are things leading up to this experience. And then opposites can be integrated to form a closer approximation of the truth. And this, I think, is the most important thing to understand. The DBT folks make a big deal out of changing the word but into and, right? So I'm angry at my mother and I love her, right? That's closer approximation of the truth than just I love her or just I'm angry at her. Right? Relationships are complicated. So there's 4 modes of DBT work. There's the individual therapy, which involves a pre-treatment process, similar to OCD work, kind of getting people on board with the model. There's the use of diary cards, so basically these forms that people fill out where they're identifying, what's the problem that I want to be better able to monitor and address. Is it my predisposition to self-harm, I have trouble with my suicidal thoughts, or maybe there's other maladaptive issues going on, substance use, whatever. I'm going to track these things. Whenever they're coming up, I'm going to use this form to identify what I did, what was helpful, how hard it was, what my distress levels were. What's the purpose of all of this writing and all of these forms is to increase insight, so that people can have more agency over their own experience and not just have their thoughts and emotions have their way with it. Then there's the skills training part of DBT, where they go over the different skills. I'm going to walk you guys through a few of them. Now DBT famously uses intercession contact to its advantage. Right? These are people who we're starting from the premise that they can't solve their own problems in the moment. And so it is a little bit different from the OCD work, where we tend to be, pushing for autonomy, pushing for boundaries and limits, and don't call me between sessions. That's reassurance seeking. I think different practitioners can have different levels of flexibility with this. I've had experiences where responding to that one email in the moment, to that one patient, really helped them step up and do that exposure, and then that actually worked, right? Then from there they really started getting better. And had I just ignored them or said it's going to have to wait, well, they might have just done a bunch of compulsions because they felt invalidated and didn't know what to do and missed that opportunity. I've also had this backfire, where because I was available once, I'm expected to be available forever. And then when I say, hey, we should probably discuss the boundaries, you hate me. Why did you do this to me? It's not fair. You sent me out. I did. But DBT emphasizes phone coaching, right? If you try to use your skills, the skills aren't working, we don't want you to die, right? I cannot help you if you're dead. Incidentally, a patient of mine and I are working on a workbook, which is the CBT workbook for the recently deceased. And this is sort of our new way of communicating. And so she's getting, this is a young autistic individual, she's getting so much out of being able to be creative with these ideas. It's dead people need CBT too. You'll see it. It'll be good. She promised not to kill herself until we published it. So. DBT necessarily involves a consultation team. OCD therapists can, work in clinics, work in hospitals, but we can also be very isolated at times. And so DBT requires that the DBT practitioner be getting some kind of support, because you're working with people who are very intense. They're struggling with intense emotions, and these are very powerful relationships, and you have to be able to do your own process work as well. So the consultation team is an important part of DBT. In the individual therapy, there's a hierarchical focus. So Basically, you can't do any of the fun stuff until we've gotten past level 1. Right? Level 1 is dealing with life-threatening behaviors. Right? What is it that you're doing that's putting your life at risk? And then part 2 would be the therapy interfering behaviors, which might include things like your compulsions. Then you move on to the quality of life behaviors, actually like making changes and improving your life, and then skill acquisition. So typically you would see OCD coming in at level 2 or level 3, but as you all know, OCD behaviors can also be immediately life-threatening, and sometimes you have to go at the OCD either at the same time or before you can get to some of that other stuff. We make this mistake sometimes of, again, looking at the models like they'll do the DBT and then they'll be able to do the ERP. I think there are many situations where you kind of have to wait on treating the OCD until some other thing is put in place. One example I could think of might be certain neurodivergent individuals who need very specific skills in order to understand how to tolerate the distress that comes from ERP. And if you just push the ERP angle without putting that first part in place, it's cruel, essentially. But I think in most cases, you're not going to want to do this and then do that if someone's coming to you and they have severe OCD or they're really struggling with their unwanted thoughts. So they divide the skills in DBT into 4 main sections, and I'll go over these in more detail. But they're mindfulness, distress tolerance, interpersonal effectiveness, and emotion regulation. So we'll start with mindfulness. I've already spoken a bit about mindfulness. How was everybody's first bite? Yeah, I know, you all forgot. Me too. I remembered on my 10th bite of beef burgundy. So good. So what do we want people to do? We want them to pay attention on purpose. Show up, including the paying attention to something that might be uncomfortable. We want people to be able to describe the world around them and their thoughts and feelings, right? So somewhat in line with ACT and diffusion, right? I'm having a thought, I'm having a feeling. We want people to also see, like I see the lights, I hear the sounds, and to be able to describe them rather than just judge them. I hate this, this is unpleasant, or this means something. No, we want people to actually see things the way they really are. This is part of emotion regulation too. We want them to get out of the story and back into reality. So if there's a problem in reality, we can address it. We're going to balance the logical and emotional self. We want people to be present, right? Not daydreaming, not trying to numb themselves out. In mindfulness, we do what's needed and effective. It's not always what you want to do or what feels good. And making choices that are authentic and balance the short and long-term goals. You might have a short-term goal of relieving your distress that then creates a long-term problem if the way that you relieve distress is to abuse a substance, for example. So we want a balance of the short-term and long-term goals. In DBT, they talk about 3 different states of the mind, and they put a big emphasis on wanting to get into the wise mind. So you have this sort of reasonable mind that's very rational and very logical, and that's where all your thoughts are, and you have them very organized, and here's what you're supposed to do, and here's how you're supposed to do it. That's my dad. And then you have the emotional mind. It's all very much feeling, very intense and loving and distressed and I'm anxious. And that's my mother. And then they made me the wise mind. Balances the two. In mindfulness and DBT, they talk about what skills and how skills. Right? So what skill? Being able to observe, describe your surroundings, participate in your surroundings. You're all probably familiar with different grounding exercises, like 5, 4, 3, 2, 1. Name 5 things you can see, 4 things you can hear, and so on and so forth. Again, bringing the person back down, out of the story, back into reality, getting them engaged with the present moment. And how do we want them engaged in the present moment? Without judgment, right? Focusing on one thing at a time, not trying to solve all their problems, and doing it in a way that is effective, sustainable, can be reproduced. One way you might kind of think about this flow chart, right? If someone is paying attention to their anxiety about a test, and they're not being mindful, and they are being judgmental, they're going to be thinking, this is bad, I'm always going to be anxious, this is awful, I'm never going to pass this test, I'll be a failure. You see how people can kind of escalate their own distress, right? And these are just patterns that they're used to playing out. Versus approaching the same issue mindfully, right? Objectively, honestly, experience-based. I am worried about a test, it's true. I can notice that my heart is racing, my palms are sweating. I notice that I'm breathing more quickly. All right? I notice that my thoughts are coming at me very quickly. I feel hot, right? These are all things that are happening in the present moment. And being able to position yourself in relation to those then opens you up to, okay, is this something I need to accept, or is this something I need to change? If I need to accept it, I can do that because I'm over here and it's over there. If I need to change it, I can do that because I can see it, I can see where I can make changes. If I'm inside it, we have all this judgment and other stuff, I'm just spinning, right? This is my favorite meme. So that's mindfulness. Now we're moving into this other skill set called distress tolerance, right? So people need skills for getting through difficult, emotionally painful moments. A lot of times on the unit at the retreat at Shepherd Pratt, I'll see people who are, they're doing the work, they're getting better, they're doing the best they can, and they just have a phone call with a family member that just didn't go the way they wanted to, or a meeting with a doctor that they didn't like what they heard. And they're just sort of knocked off track, and they can't think straight. And they hate everything, they want out, they want to leave the hospital, they're never going to get better, it's a disaster, right? And they were doing so well, but it was just like one thing didn't land the way that they wanted to, and they hadn't developed the resilience to be able to tolerate that one thing. So what they need is to be able to tolerate that experience long enough for it to fade away on its own so that they can then reflect on it and then learn from it and then understand, like, how is it that I thought I was doing well, but then I got pulled back over this other direction. So this might include things like self-soothing and using physiological kind of activity to re-regulate. And it's a big focus here. How do you get back to accepting reality? I am in distress. I don't want to be in distress. Okay, but you are in distress. How do we work with the fact that you're in distress? We do the same thing in ERP, right? If someone's, doing the exposure and they start to get, ramped up and like, this is bad, I don't like it. Yes, it's bad, you're doing great, right? We want them to be able to show up for that experience and be a witness to it getting better as time goes on. And sort of the reason I like this meme so much is we often tell people to sit with discomfort, and and some people have a tendency to interpret that as sort of putting, having discomfort sit on them, right? Like, and being kind of like totally immersed and attached to the discomfort and focused on the discomfort. Instead of it, you're thinking of it as sitting next to you. You're sitting with it. There it is, right? It's very uncomfortable. I see that, and also here I am in reality with my friends, and I can handle this. Right. So some distress tolerance skills that are popular in DBT, tip skills. So one is using temperature. So on the unit, a lot of times we use these frozen ice packs and things like that, just to get people to feel anything different than what they're feeling. Put it on their neck, put it on their face. Another exercise that's used here, if you want to really go all in. I haven't actually tried this myself, but you get a bowl of ice water and you have the person really immerse their entire head in it. And this eventually triggers the dive reflex. It makes your brain think you're in the ocean, which makes your heart rate go down. And everything I've read about it sounds like it's very effective. We keep frozen oranges on the unit. Again, sort of lighter version of it. Hold the orange, just kind of feel it gently softening up in your hand. Pay attention to the sensation in your hands. Intense exercise, right? How many do as many push-ups or jumping jacks as you can. People be very, very resistant to doing this. But if you get them to do it, it does make a difference, right? It sort of triggers this anxiolytic response in the brain. Also gets them focused on something other than the problem that has them so worked up. Paced breathing, pick your favorite, whether it's box breathing or some other kind of breathing, but really kind of intentionally breathing in, holding it for some period of time, intentionally breathing out maybe a little bit longer than you're breathing in. So you're changing up the oxygen carbon dioxide ratio in your head. A lot of times people are breathing these short, rapid breaths. All of these anxious things that we do, they're adaptive, they're useful. If you're going, you're fuel injecting your brain with oxygen. It makes you more alert. It's good if you're about to be attacked by a bear. It's just not good when you're in therapy or you're trying to get along with a loved one or something like that. So changing that ratio very intentionally changes the brain. And then you compare this with progressive muscle relaxation. Some people do very well with the very traditional, tightening up the muscle, loosening the muscle, right, and working your way down the body. I find that a lot of people with OCD and anxiety struggle with that because when they tighten up, they stay tight. So visualizing it works pretty much just as effectively. Just really imagining, kind of printing yourself out, doing a body scan, and imagining as you scan down, the muscles in your body are softening, relaxing, right, all the way down to your toes. Radical acceptance. Stop fighting reality. Oh, but it's so bad, is a way of fighting reality instead of looking at what's really going on. Recognizing the facts about the past and the present, even if they're uncomfortable, right? Really just coming back to, okay, but what is? It might sound counterintuitive. You might want this person to not be thinking about it, but if the goal that the two of you have agreed on is distress tolerance, then actually opening up to reality the way that it really is how you're going to learn to tolerate that distress. So embracing it rather than rejecting it, breaking that cycle of suffering, unhappiness, and anger, all these other unbearable emotions where you're fighting the experience instead of just seeing the experience happen. And I like this idea, reality really doesn't care if you like it or not. Liking reality, not liking reality doesn't change reality. DBT uses this language, willingness versus willfulness. So are you willing to really participate fully in life and living, which really requires you to be willing to participate fully in being with your unwanted thoughts and emotions. Willfulness, right, that would be refusing to tolerate the moment or to make the changes. Would mean giving up on yourself, or mean insisting on being in control or fixing every situation. So we want to find out if people are being willful. It should be this way. I want it to be this way. It's not fair that it's this way. And see if you can switch them over to willingness, to give the power back to them, say, okay, I can be open to this experience. It's not easy, but I can do it. Again, we see this in OCD. I shouldn't have these thoughts. I don't want to feel this way. Okay, but what if we could change this? I'm willing to have these thoughts. I'm willing to feel this way, and gradually kind of get used to this idea of dealing with what's real and not with the stories about it. So here's just like a little sort of flow chart how you might do that in DBT is if you're in a situation where you're very distressed and you're having trouble tolerating that distress, you might start by observing that you're fighting against reality. My boyfriend shouldn't have said this, or that my therapist doesn't understand me. It's not fair. And then reminding yourself that the unpleasant reality can't be changed in this exact moment. Right? This is the situation. It's not going to change. That's what happened. Here I am in reality. Something led to this moment. Right? It didn't come out of the blue. There was an experience I had before I became distressed. And I'm going to really practice acceptance, not just with my mind, not just by telling myself, here I am practicing acceptance, but with all of it. I mean, for those of you who are very experienced doing ERP, you might see people doing exposures. It kind of looks like they're doing exposures, but they've got this very distressed look on their face, and you can see their body is kind of like this. So I'm always trying to encourage people, like, let's get rid of everything that might be sending a signal to your brain that you don't want to have this experience. And get your brain to understand that you are truly willing to have this experience. And that might just start with unfold your arms while you're doing this exposure. Right? Adopt a body posture of a person who is truly willing to be here in this moment. They have other sort of skills. They might kind of get this idea across, like half smiling, or the willing hands. And then list what your behavior would look like if you did accept the facts, and then you actually can write it down. Like, okay, if I could actually tolerate that this is what's going on, what would actually be helpful? Again, what would be helpful now is part of radical acceptance. A few more skills for dealing with distressing emotions. Again, you can't think straight until you regulate, so you have to do something other than think hard while you're in that state. So accepts is a nice little acronym here, right? Find some activities and engage in them. So I see people on the unit doing Sudoku and jigsaw puzzles and things like that. They're doing the best they can. Find a way to contribute to others. Give yourself a purpose, like, oh, I'm going to help this person with this thing now. Sometimes it can be helpful to engage in sort of adaptive comparisons of, like, this is a difficult situation, and I'm doing the best I can to put up with it. But my country's not at war right now, and again, you got to be careful with that because some people can be very kind of self-shaming and blaming, like, oh, look at me, like I'm complaining, and there are people who don't have enough to eat. So you don't frame it that way. You just frame it as like, this is something I can tolerate because I know there are things that I can't tolerate. I'm grateful that I'm not having to tolerate those too. Right? Labeling and identifying your emotions. Again, we're so heavily trained in telling people not to push things away, but sometimes you just push it away. It's all right. Just put it on a shelf. Don't deal with it right now. It can be compulsive to deal with things in the moment sometimes, when the smart, wise-minded move would be to wait. So instead of compulsively dealing with it right now, let's shelve this. Let's put that emotion up in the cloud. Let's put that story up in the cloud. Hard for me to deal with right now. I'm not going to deal with it right now. I'll deal with it later. Connecting with positive coping statements. Again, not compulsions, not reassurance, but objective coping statements like, this is hard. I can handle this. I'm a strong person. I'm having a difficult time. There are a lot of people around me, supporting me. Right? I'm not alone. These are all fair game. And then maybe try to just change your sensory environment if you're dysregulated to create some positive physical sensations, a warm bath or something like that, or fuzzy blanket, or something that just makes you feel automatically regulated. I've been on several mindful meditation retreats, where you're silent for several days, and you're sitting and you're walking, and you're hearing Dharma talks. And one of the things that I learned the first time I went to one of these retreats was that I really like ginger tea. I've never had it before. And, you don't have, there's not like a lot to do, like you're intentionally not doing much, so you end up drinking a lot of tea if you're kind of a nervous sort. And now, whenever I just smell the ginger tea, immediately I feel like I've just meditated for half an hour, because in real life, I had just meditated for 8 hours and had some ginger tea. So the brain kind of draws these associations. So, that's why people get into things like aromatherapy, like why it kind of immediately helps them deal with some of their emotions. Looking for ways to improve the moment. The moment is awful, okay, and you can't fix it. Okay, can you improve it? Can you engage, in some positive imagery? Can you watch some YouTube videos that make you laugh, or look at some artwork that makes you feel good? Can you connect with your faith through prayer in a non-compulsive way? Or do things that are relaxing. Stick to one thing at a time. Take a brief vacation from whatever you're doing. Come back to it later. Focusing on like encouraging yourself. Like, okay, I can get through this. This is hard, but I'm gonna rethink this situation from something I cannot tolerate to something I can tolerate. You could also take a more methodical approach, like using the pros and cons of acting on urges. So we do this, I think, in the way we approach cognitive restructuring for OCD, when we're doing this sort of third column challenge of the cognitive distortions. We're basically saying, whether or not it's really in my best interest to do compulsions, right? So a good reframe might be, this is really triggering in my experience. Doing compulsions is going to make it worse, right? It'd be a good idea for me to go do something else, right? So you can do that with pretty much any kind of maladaptive urge, including something like self-harm. Because someone's just like so focused, and like the next thing that has to happen is me hurting myself in some way. Okay, well, let's see. What are the pros of acting on these urges? Giving in, doing what the voice wants you to do, avoiding what you really need to do, which is learn how to tolerate these experiences. What are the cons of acting on these impulsive urges? What brought you to the hospital, and how's that working out for you? What are the pros of resisting them, right? Like, what will you be able to do if you're able to resist them? And be honest, what are some of the cons of resisting them? Like, what, having to deal with this intensity that you don't feel particularly adept at dealing with. So we've covered mindfulness, and we've covered distress tolerance. So let's take a look at emotion regulation. So again, distress tolerance is more about sort of like getting through something, whereas emotion regulation is really about really fundamentally changing something. So we want to increase the awareness of and understanding emotions, identify the experience, again, identify them accurately, and then decide what needs to be done. Do I need to be upregulated because I'm so distressed, so depressed rather, or do I need to downregulate because I'm so ramped up and in such a space of intensity? And then what are skills that can kind of toughen me up a little bit to reduce my vulnerability to being dysregulated, so that I don't have to rely so heavily on skills? Can I learn how to let my emotions come and go without fighting? Can I be more mindful, in other words? Okay. How can I change my behavior to change the way that I feel? Again, perfectly compatible with exposure therapy. I'm going to act like this isn't scary, and we'll see how long it takes my brain to decide it agrees with me. Right? I'm going to act like I do matter, and see how long it takes for me to get out of this suicidal fugue state. So you can use other skills to kind of just increase your awareness of what you're feeling and just the reality that you're feeling, right? So instead of getting rid of it or pushing it away, and instead of being immersed in it, can you just notice where in your body you're feeling these sensations? Can you experience the sensations fully, completely? A lot of times people say they're just picturing themselves a little homunculus in their head, and they're describing, I'm anxious, I'm anxious, I'm anxious. And you ask them, what's it like in your body? And it's like they've never heard of the concept, you know? Well, where are you anxious? Well, I'm just thinking that I'm anxious. Okay, but how do you know? You can kind of help them recognize, you know, it's a heaviness in the chest, tension in the shoulders, lump in the throat, heat on the face. Can you actually kind of get out of the story of I'm anxious and into the experience of my body is having, you know, these sensations? Can you notice the urges that come with that? Like your desire to not feel this way and the urge to change how you feel with cutting or self-hitting or abusing a substance or something like that. But not act on these urges, just notice that they're there. You know, in the DSM we describe obsessions as unwanted thoughts, images, and urges. And people almost never think about the urges part of it. Your patients will come to you and say, but this is different. It really felt like I was going to reach for the knife, or I really felt like my hand wanted to turn the steering wheel. And you pull out the DSM and say, look what it says here about obsessions. Right? Unwanted urges, isn't that wild? Can you name the emotion based on, you know, the sensations in the body and the urges, and what's actually going on here then? Right? Can we identify what this is and acknowledge that you could ride it like a wave? Another thing to think about, right, is we have a baseline. So if you're able to say I'm anxious or I'm depressed, right, that means you're off baseline. And by definition, if you know that you're off baseline, it means you must know that you have a baseline, which means you must at some level understand that your experience is impermanent, because it's not always this way. I often see people, this is more of a cognitive thing than an emotional thing, but you know, identify their experience as being totally negative. What they really mean, though, is that they were negative at 11 o'clock, and now it's 1 o'clock, and they're still negative. And they're not really recording anything in between. They're just sort of saying, look, it's been negative the whole time, because they're not being mindful. They're not paying attention. Right? Has anybody had the sugar cookies? They're really good. And you could be having a terrible day, but you could have like one moment where you bite into that cookie. And it's just an objectively delightful experience. You immediately go back into, I shouldn't have eaten it, and why would I? That's fine. But the reality is, it wasn't all negative. You just weren't documenting everything that was going on. Another way to sort of think about this is you sort of thoughts and feelings, you know, they're going by on a conveyor belt. They're constantly moving. And what many of our patients tend to do is, instead of, you know, stepping aside and watching the conveyor belt, that would be the mindfulness thing to do, they're like, this is fine, this is fine, this is fine. No, that's not okay. And they watch that thought move over there, and they're busy over here trying to fix it with their compulsions and their self-criticism. I shouldn't think this way, I should have these thoughts, now I get rid of them. But the conveyor belt's still moving, which means all of their other experiences, simple experiences, how blue a sky is, how wicked a bass line is, and some songs playing in the background. They're missing all of that, and so they're thinking of their life as very negative because they're not paying attention. Right? They're getting distracted by these other things. Part of what we're training people how to do is like, this is fine, ooh, I don't like that, okay, let's let it go, this is fine. Like the I Love Lucy thing with the chocolates, right? Really learning to step back and watch the conveyor belt. Or in this case, kind of, you know, view your emotions as being part of the wave. If you know you're off baseline, it means you know there is a baseline. So in DBT, my favorite, of course, is going to be the skill of opposite action. Now, it doesn't just mean do the opposite of what you want. It's not the same thing as exposure, but the idea is that you're having one emotion, and you want the opposite to be the case, so you should pick a behavior that's consistent with that opposite. so that you kind of turn your emotions around, right? The emotions propel us to act. So we want to choose behaviors that are consistent with the opposite of the unwanted emotion. The unwanted emotion, is going to be asking for, in the case of anger, to maybe yell at somebody, right? But instead, let's see what happens if I intentionally express gratitude and kindness towards this person. Or shame, right? Famously, shame makes you want to isolate yourself. It's an emotion that has something to do with this idea of like, I'm bad and I've broken a societal rule and I need to be removed from the village, and so you're going to have your head down and you're going to be closed off and you're not going to want to be making eye contact. You're going to be sort of positioning your body as if everybody's around the campfire and you're like over there waiting to be eaten by a coyote. So what about head up, shoulders back, eye contact, getting in the right? Playing the part of the opposite emotion to kind of stir that change. Depression is a very kind of interesting one because we think of some of the symptoms of depression, lethargy and hopelessness, worthlessness. We don't really tend to talk about these things as symptoms, but that's really what they are. Apathy is another one. So people will complain about these things like, I don't care, nothing matters, and they're not understanding that your belief in this moment that nothing matters is actually a symptom of your depression. If you weren't depressed, you'd find other things, you'd be much more engaged. You might still be very upset all the time, right? If you read the news or whatever, but you wouldn't be in this space of like, I don't count, nothing matters. People, even something like worthlessness, like I've concluded that I'm worthless, it's actually not a conclusion, it's a symptom. So what do people do when they're depressed? They isolate, they close the blinds, they don't engage in social activity, they stop exercising, they maybe don't eat, or they eat in a way that's not healthy. But it's very hard with people who are depressed because what works, right? Behavioral activation works, opposite action works, getting them to exercise, to be social. But I think it's just worth acknowledging that you're asking them to do this while they have symptoms that make that very difficult, right? So that it's not an even playing field. You're asking them to, find the motivation to get on the treadmill when they physically feel like they can't get out of bed. So I'm not saying it can't be done, but you should let your patients know that you understand why it's very hard to do that with these symptoms. Right? What do we do with ERP? Someone's afraid of something? Okay, so we're going to go toward it. That's how you're going to overcome it. Same concept. Disgust, right? And so instead of reeling from it, I'm going to try to figure out a way to embrace it and take it all in. Stop, right? There's a very simple strategy, and it really just means, pause, be mindful. So this is the stop skill as part of emotion regulation. So you're just kind of careening, you're like a train headed off a cliff in an old western, right? You're just like headed towards self-harm, headed towards disaster, headed towards the worst compulsive thought you've ever had. Stop, take a step back, observe what's going on, make a plan, mindful plan, proceed planfully. So a lot of times what's happening with people who struggle with emotional dysregulation is that things are happening too quickly. And they have to actively and intentionally slow them down to be able to see what's going on before they can intervene. Of course, remember this isn't thought stopping. This isn't like picture a stop sign every time you have the thought in your head. This is more of like get out of the centrifuge and